here in Franklin Park. And we are also joined by Trinity Lutheran Church in Franklin Park. And we take turns producing a once a month lecture on something related to racial injustice. So this month is our turn. And I know our minister, Reverend Jane, just started recording it. And hopefully when we move into the speakers portion, you'll be able to record the speakers only. And we're just delighted to have everybody here tonight. We'd like you to put your questions in the chat, and we expect that the talk will go maybe 40, 45 minutes, and then we'll address the questions afterwards. So I'd like to introduce Anne McCarthy, who is the former clinical director and midwife emeritus of the Midwife Center for Birth and Women's Health, and located in Pittsburgh, down in the Strip District. And also we have Winter Hall, who is a doula, a marriage mentor, a registered nurse, and a co-founder of Masters of Maternity, which seeks to provide a doula directory so that all pregnant persons can get the support they need for a successful birthing experience. Okay, so I think that's it. And please proceed, Anne and Winter.
Thanks. Like I said, thank you so much for having us. I'm so glad that you do this. It's really important work. And Winter and I are both really happy to be here tonight to present to you. Like Liz said, I am a nurse midwife. I moved here 17 years ago to work at the Midwife Center, and I'm just going to briefly explain midwifery and the birth center to you all. And that's where I had the privilege of meeting both Diana Hall, who took such good care of me when I moved here as a nurse at the birth center. And then later in my years there, I met Winter, who worked as a nurse at the birth center as well. So lucky to know these two people. And I'm really grateful to Winter for agreeing to present with me tonight. Go ahead, Winter. Wait,
you're muted, Winter.
We still can't hear you. Wait, here we go.
Okay, sorry.
There you go. No, you're good.
I'm going to keep myself on. I'll just be quiet. But I apologize. Super honored to, can you guys see the screen?
No, the share screen is off, but that's okay.
Sorry. Okay, sorry guys. Super honored to be here. As Anne mentioned, we met at the Midwife Center, and it's just an amazing place where I feel like I evolved as a nurse. My background, I worked at McGee for 3 years on the high risk unit. And then I cross-trained on postpartum, and I started to just see a lot of different things and discrepancies about how women of color were treated in the hospital setting, and wanted to do something about that. And then personally, I just started living and looking at birth as a more holistic thing instead of a disease. So I transitioned over to the Midwife Center. And again, I just loved it because it really helped me not, I had to unlearn a lot of different things on how I cared for the population. And then I also was able to make sure that I was teaching people their options and not just telling them their options. So that was just a beautiful, beautiful experience. I then transitioned into a doula because I really enjoy bedside nursing. And as a nurse, you have to do other tasks. And I like going into the household. I like making sure that clients understood their rights and that they were able to advocate for themselves in the hospital setting or the birth center setting. And so I transitioned into a doula in 2019.
Thanks, Winter.
Okay. I'm going
Okay.
to share the screen now.
Yeah, Winter's going to do my slides for me. So I just want to first of all explain that when we were asked to do this presentation, I acknowledge my place as a white provider working in a healthcare system that was built on and still upholds white supremacy. And so in that thought, I asked Winter to come and present with me, but I wanted to do the majority of the work preparing for this presentation. So I'm going to do a lot of talking, but all of you have the privilege tonight to have Winter and her partner Alita here in your presence, because they are true change makers in Western Pennsylvania. And I want to give you time to talk to them, but also to explain that that's how we prepared for tonight, out of respect for Winter's time. Okay, so next slide, real quickly, I just want to explain, a lot of times when I do a talk, people have never met a midwife before. And so I like to explain what a midwife is. So I have my undergraduate in nursing and then my master's degree in nursing as well. And we sit for a national board exam to become certified nurse midwives. In Pennsylvania, we're licensed by the State Board of Medicine, have malpractice insurance. And there are different types of midwives. Pennsylvania only licenses certified nurse midwives, unfortunately. And we can both work in hospitals and freestanding birth centers and do home births. When I moved to Pennsylvania, I moved here to work in the freestanding birth center called the Midwife Center. So I want to talk to you a little bit about that. And maybe you've heard of midwives in other countries. For instance, in England, the princess was attended by a midwife. It's very standard in other countries, and those countries often have a lot better outcomes than the United States. So I'm going to talk about statistics tonight, but I just wanted to give you a basis of what a midwife is. And Winter, do you want to briefly explain what a doula is?
Yes, so the root word of doula means servant, or a woman who serves. So there are different types of doulas, but for just time's sake, I will talk about birth doulas. And so what they do is they are there for the mom to educate them, to be their emotional support, physical support, and then advocate for them throughout their pregnancy, their birth, and the postpartum period. That's basically what it is in short.
Thanks, Winter.
Yeah.
Okay, so the next slide shows you the Midwife Center for Birth and Women's Health. So this is located in the Strip District in Pennsylvania. And we're lucky to have the largest freestanding birth center in the whole country. So a lot of other, Winter, do you mind going to the next slide? Thanks. We are looked to by the country as one of the leaders in freestanding birth centers. The addition was put on in 2017, my goodness, which made us the largest birth center in the United States. Real quickly, can you go to the next slide? What is the birth center? Okay, you can do the next one. A birth center is a freestanding home-like facility existing within the healthcare system. So we work really closely with the hospital system with a program of care designed in the wellness model of pregnancy and birth. So like Winter briefly mentioned, midwives and birth centers take a person who's pregnant and put them in the context of being well, since most people are well, 85% of people qualify for midwifery care, and watch closely. You can see guided by the principles of prevention, sensitivity, safety, appropriate medical intervention, and cost effectiveness. So again, this is the standard of care in many other countries. Just a little bit about what we do, our services. You can go to the next slide, please. And the next one. So we do primary gynecological care. So a lot of people don't know we do more than just prenatal care. So it's important to know that a lot of outcomes for pregnancy are influenced by what happens way before pregnancy. So that's why we try to meet with people before they even become pregnant, help them decide when they want to get pregnant, and take care of them before they're even thinking about pregnancy. And then we also do prenatal care, childbirth, postpartum care. Like I said, we do birth center care and hospital birth care, including water birth at the birth center. And then when the expansion happened, the Midwife Center added behavioral health and wellness, because we are realizing that the more prenatal care we give, we're not having better outcomes. So we need to look differently at how we are taking care of people in pregnancy and what we can do to change outcomes, which is what we're going to talk about next. So lactation support classes, walk-in programs. One of the reasons I moved to Pittsburgh was because the Midwife Center has always had a dedication to the most vulnerable people. We're very strategic about placing the birth center in an urban setting. Many birth centers across the country are boutique and they're in wealthy suburbs of cities, and that's not how the Midwife Center is. So if you can tell, both Winter and I are very proud of the work that they're doing. And then there's outreach, educational opportunities, and I'm going to talk about why that's important a little bit later. All right, so there's a picture of the birth suites. You can see there's a water birth tub. The picture up on the right-hand corner, Diana Hall, who's on this call, who was a nurse at the birth center, if you missed that part, she would make the most amazing omelets after someone had a baby. I really credit Diana with all my omelet skills, and families really loved having an omelet after delivering. But you can see it's a home-like facility with many supplies for emergencies. We can handle many emergencies and a lot of risk stratification. So people would only come to the birth center if they were low risk, and if they were high risk, we would take care of them at the hospital. All right, and then you can see the exam rooms too. So if anyone on this call has ever had a pap smear done, I'm sure you have gone to a room that doesn't look like this. We're really trying to establish trust with clients, and establishing trust is something that is really important into taking care of the whole people. So there's a picture of one of our exam rooms. All right, so let's talk about statistics. So I always like to start off with this slide, especially if I'm talking to people in Western Pennsylvania, because I think it really hits home. This is a slide by the Society for Maternal Fetal Medicine, which are the high-risk obstetricians. So if being a pregnant Black woman were an occupation, it would be the 5th deadliest job in the country. For a Black woman, becoming pregnant in the 21st century is more dangerous than being a steel worker or working on a construction site. All right, let's go to the next slide. So first, I want to talk a little bit about statistics for the whole United States, and then I want to talk about Western Pennsylvania. So maternity care in the United States is the most expensive in the developed world. So we spend more money than any other country. Probably, I mean, the statistics are appalling at how much money we spend on it. As you probably know, it's dominated by the medical model delivered by physicians, usually obstetricians, even for low risk pregnancies. And there's no disrespect whatsoever to the obstetricians that work in the United States and in Western Pennsylvania. It's really important in order to have safe outcomes to have relationship with obstetricians, but they're by training surgeons. And so right now, about at least 1 in 3 pregnancies ends in a cesarean section. And our statistics for maternal death are going up. So the rate of maternal death is rising in the United States. You probably know, if you've been in for healthcare appointments across all settings, appointments are very quick. There is a financial incentive to see a lot of people in one day. And so what has changed is that there has become more of a lack of trust in the healthcare setting across all divisions of medicine. Okay, next slide, please. Okay, so about 10% of US infants are born preterm every year. Statistics are much worse for the Black community, and I'm gonna talk about that. We rank 54th in the world in rates of preterm birth. With all the money we spend, all the technology we have some of the worst rates in the world for preterm birth. And preterm birth is a leading cause of infant mortality. Preterm birth rates have remained intractably high. They've risen lately in the last couple of years. And if a preterm baby does survive, you can see that there's short and long-term healthcare problems for babies. So respiratory problems, feeding difficulties, infections, developmental delays, impaired vision and hearing. So there's a real incentive to make sure that babies make it to a full-term pregnancy. So 10%, that's 1 in 10 babies are born preterm. Okay, we can go to the next one. So let's talk about Pittsburgh. So in 2019, the University of Pittsburgh, the city of Pittsburgh put together a commission, the Gender Equity Commission, and they charged the University of Pittsburgh researchers to talk about what are the actual statistics in Pennsylvania for our Black community. So as you probably can predict, the results were not good. And in fact, so findings for the Black community were not good across all of the things that they studied. So they looked at long-term healthcare needs, like heart disease, things like that. They also they looked at employment, income, education. So it's a very interesting report, and there's some really good summary studies or summary articles that I can share with you in the links if you want to read about it. But the findings for Black women in Pittsburgh were particularly troubling. In evaluating how life was going for Pittsburgh along the lines of gender and race, the study finds that white men and women are mostly enjoying either average or above average standards of livability compared to other racial groups in the city. So you might see, like in the news, like Pittsburgh's the most livable city or one of the most livable cities. And I think it's really important for everyone to understand that that is for white people in Pittsburgh. Okay, let's go to the next slide, please. So I'm going to say a lot here in this next slide. This is only just one statistic that I pulled out, but this is fetal mortality rate when we looked at Pittsburgh versus peer cities. So you can see here when we look at the top, fetal mortality rate, I don't know if you can see the line down the middle is the same as your peers or better than worse than your peers. So you can see white women are not faring as well as other cities in terms of fetal mortality rate. Black women are doing much worse. And then the acronym AMLAN is Asian, multiracial, Latinx, other, or Native American. And again, you might not be surprised by this, but this category of people in Western Pennsylvania and Pittsburgh is too small in numbers to be analyzed separately without compromising privacy concerns, according to the study. So there just weren't enough of those other demographics. Pittsburgh's actually not a very diverse city when it comes to that group of people. Okay, so for Black women in Pittsburgh, 18 out of every 1,000 pregnancies ends in a fetal death, compared to 9 in 1,000 for white women. So, which also is not good, of course, compared to other cities. So Pittsburgh's Black fetal mortality rate is higher than it is in 94% of similar cities across the United States. So, you know, as you probably have heard, Pittsburgh is very proud of our healthcare, but we are really failing this community in Western Pennsylvania, especially when we compare ourselves to other cities, similar cities across the United States. The city's Black mothers also gave birth to babies of low birth weight at twice the rate that white mothers do. And it ranks in the bottom 25% of cities for Black mothers experiencing low birth weight for their babies. Black women in Pittsburgh are more likely to die during pregnancy than their peers in 97% of other US cities. So I just really want that statistic to hit home. A Black woman could go to 97% of other cities in the United States, similar size, and have better outcomes than here in Pittsburgh with all of our healthcare that we have that, you know, we are very proud of. So we are really failing them. This is another interesting statistic from the study. Black women also in Pittsburgh die by suicide at higher rates than most other cities. And what's interesting in the report is that they contrasted white men, and white men die by suicide at much lower rates in Pittsburgh than they do in other cities. So again, this is the most livable city for a certain category of folks. I think there's some questions. What is the risk job is for non-Black women? Connie, do you want to ask that first question? I'm not sure what the first question is. Do you want to unmute and ask? Well, we can come back to it at the end. All right. So those are the statistics for, and I just pulled out, I can share the link. I think I put it on one of the slides, but I can share the link with all of you so that you can go look at this study too. It's important that we know this and that we are, this is actually a crisis here in Western Pennsylvania and Pittsburgh that we need to be addressing. Okay, so why? So maybe an easy explanation is that Black women don't receive prenatal care. Actually, that doesn't explain the reproductive crisis in Pittsburgh. The study also found that Black mothers start prenatal care at the same time as white women and the other category, the AMLON category of mothers, which is around 10 weeks. In fact, the researchers from this study found that Black women on average begin prenatal care sooner than Black women do in 92% of other US cities. So the answer is not that they are not getting health care here in Western Pennsylvania and Pittsburgh. Same with the problems of low birth weight and other defects. We can't blame that on educational or economic status. So this is across the country too. I think it's really important that people understand that you can't blame education or economics for these outcomes, because some people say, well, they're poor, you know, they don't have resources and things like that. In the United States, we should be so ashamed of this because we don't have any different genetics from Black women and white men have no different genetics. In the United States, a white woman who does not have a high school education still has better outcomes than a Black woman who has a PhD. And maybe some of you have heard Serena Williams' story from, she was in Atlanta and had a baby, and the fact that she wasn't listened to and almost died in her pregnancy. So I think she's a really good example. If Serena Williams, who probably is the GOAT of tennis, was not listened to and almost died in her pregnancy, there's another, my good friend she works for the CDC. She's an epidemiologist. And one of her friends also had a PhD, is a Black woman, and she actually did die from complications of childbirth, working for the Center for Disease Control in maternal child health, and still died having her baby. So this is not a result of economic or educational status. Like I just explained, the racial disparities on this front existed for Black women, whether they were college graduates or WIC recipients. So racial inequality, not education or income, drives the observed inequities per the study. So what is it then? So the next slide is a tweet from a Black obstetrician who I had the pleasure of presenting with one time, who I very much respect. If you're on Twitter, I suggest you follow her because she is brilliant. And I'll read it to you. So it's racism, not race, that is a risk factor for the poor health of Black, brown, and indigenous folks. Replacing Black on all the NIH, CDC, Healthy People 2030, et cetera lists, and replacing it with racism is a 2021 goal that we can achieve while we work on anti-racism policies and truth. So the fact is, if people are getting the same amount of prenatal care, if they are, their economics, their educational status doesn't matter. It's very clear that racism is a problem, and this is affecting the outcomes for Black women in our country and in Western Pennsylvania. All right, so what can we do about it? I do not pretend to have the answers here. I really don't. This is something that's much bigger than me, but I do know part of the answer. And again, that's why I feel we're also lucky to have Winter here today, because she and her partner, Lita, they are change makers. They are making a difference. They are absolutely part of the solution to what is happening in healthcare. So first of all, I would say, do your own anti-racism work. And as a healthcare system, again, built on white supremacy, the systems need to do anti-racism work. Sometimes when I give talks like this, it can sift up some very raw emotions, especially because a huge problem is that the majority of the workforce looks like me, and we're taking care of vulnerable populations. And these vulnerable populations come in and they don't have trust. They don't have trust in the healthcare system because it's not diverse. It's a system built on capitalism. So, we have to see so many people in an hour. And again, it's a system that's built on racism. So I appreciate that you're all here. I know you're all, and everyone who's in attendance tonight is doing anti-racism work. And as systems and as a country, we need to do this anti-racism work. The other very clear solution, and I want to talk a little bit about studies to support this because I don't like to just say things without backing it up with statistics, is to support doulas. There's really excellent research on doulas, and I do want to give Winter some time to talk about the really great stuff she's doing with her partner, Lita, and then to support midwives because frankly, midwives are changing outcomes. They have much less health inequity. So there's still health inequity. And I just really quickly want to go over a study that shows that. So can we do the next slide? Okay, so this was a presentation on the Strong Start study. This was a federal grant given to birth centers across the country to look at what happens with Medicaid recipients who are generally a more vulnerable population when they receive care in a birth center. Okay, you can go to the next slide. So when we looked at what happens with, well, first of all, I just wanted to explain, you can see in our Strong Start study, this was, evaluating birth centers versus national statistics. People who received care, again, they had to be Medicaid recipients, so they're on some form of assistance, had much lower preterm birth rates than the national average. So you can see 4.4% versus nearly 10%. Same for low birth weight, very low birth weight. And then the primary cesarean section rate, something really important to talk about. So midwives, we do stratify the fact that midwives take care of low risk pregnancy. So the national average of C-sections is around 32%. For low risk C-sections, and primary C-sections, the first C-section, it's lower. So you can see the difference in C-section rates for people who receive care with midwives. And I do want to point out in this study that over 50% of the people did deliver in hospitals. They did not all deliver in birth centers. Okay, and then the next slide breaks out racial disparities because this is what we're talking about. So you can see there's still disparities between Black women who are Medicaid recipients that were receiving care in birth centers. Again, more than 50% still had hospital delivery. So we're talking about the overall care here, not the actual location of where they deliver. So you can see that for preterm birth, all races that had care with birth center care had around a 4.42, percent preterm birth rate. And then Black African Americans in this study had a preterm birth rate of 4.97. But you can see that compares, like in the US, of all races, a preterm birth rate's around 9.85%. And then for African Americans, it's higher at 13.77%. I don't have a slide, I don't think, about C-sections, or maybe, can you go to the next slide? Let me see if the next slide has that. No, I didn't put that in there. But anyways, the C-section rate for African Americans is much higher too. So we can talk more about statistics. I could talk all night about that, but I really do want to give you enough time to listen to what Winter has to say too. So what is it? I mean, it's really important that diversity, inclusion, and anti-racism work happens. And one of the things that I'm really proud about the Midwife Center is that Midwife Center has made a really concerted effort to change the diversity of the provider staff. So when I came to Pittsburgh in 2004, every single provider looked just like me. We probably came from all the same economic backgrounds, very privileged folks. And the reality is that many people, especially in Western Pennsylvania, first of all, we had a really hard time attracting anybody who was a midwife of color to move to Pittsburgh. And when you look at those statistics, I am not surprised that someone wouldn't want to move here. But also that the fact that this is not something that's talked about in Pittsburgh, that we need to foster our own providers of color here. And you have to make a concerted effort to reach out to help people become providers of color. So you can see we've worked really hard at recruitment and retention of people of color, both on the staff board and advisory committee. Now the makeup of the Midwife Center, I'm no longer there, by the way. I'm working for the University of Pittsburgh Physicians because of family needs. I'm still very involved with the Midwife Center, but over half of the provider staff now is not white. And that's what changes the landscape of the clients that come to the Midwife Center too, because of the trust factor and the fact that appointments are longer, people have more time, they see representation of themselves on the pictures on the wall, of the materials that are handed out. All of that matters to people. Trust really matters. I saw Connie ask, what is it about racism that causes the lower outcomes? There's whole classes on that question, and I'm happy to give a brief answer. But again, with Winter being part of the community here and a provider, I really want to give her some time. But we're really looking at epigenetics and the fact that racism has rippling effects for generations. So, and I should even go back to slavery, the fact that generational trauma is a real thing, and racism affects every facet of life. So especially in Pittsburgh, there are populations that are living in food deserts. So they don't have, because of racist policies, they don't have access to healthy, fresh foods. They've had highways plow through their neighborhoods, so they don't have the same community setups that they have. It really affects every single thing, and that's how we see that in the outcomes. And again, there are many systems of racism, especially in Western Pennsylvania, obviously, because we see these outcomes. So anyways, this is what we need to do as a whole healthcare system. We really have to break down how can we better earn the trust of the community? How can we work on anti-racism policies so that we can improve the health and outcomes for everybody? Okay, so the next slide, I thought maybe you could just talk a little bit about doulas. I do want to just quote, again, there's a lot of really good studies that talks about doulas and the impact of doulas, but there's this quote from a really good study that I can also drop in the chat box that just kind of, for me, summed up the beauty of what doulas do, especially what Winter and Alita are doing. So one piece of the solution to help address racial disparities in care is to expand access to full spectrum doula care. Doulas can provide individually tailored, culturally congruent care and advocacy for pregnant and postpartum people through information, education, physical, social, and emotional support. So that is really the heart of what we need to do, is not dive into, you're here, let's measure your belly, let's check your blood pressure and send you on your way. This is like information, education of physical, social, and emotional support. While doulas cannot eliminate individual and institutional racism in the medical system, doulas can help improve the maternal health experience and address health disparities by reducing the impacts of racism and racial bias on pregnant and postpartum people of color. Doulas who understand the physical, social, and emotional impacts of racism can provide much needed support to their clients, and above all, act as their advocates for clients and navigate the medical systems of care. So back to Serena Williams' story. I don't know if she had a doula, but I'd imagine if she had a doula and she was calling out and saying, something's wrong and she's not being listened to. A doula knows how to navigate the medical system. She knows the ins and the outs of who to ask and what to say, and the doula can advocate on her behalf. And I really hate to say that, but even as someone who's not part of this community, if one of my family members enters the medical system in the United States, I can promise you I am there because I know what happens. And so it's even worse for people of color. And this is the real beauty that doulas add to, especially changing outcomes for people of color. So I've talked a lot. I really appreciate you listening. I really do want to give Winter some time to talk about the amazing work she's doing, because like I said, she is the solution. She's the solution to this problem. And all right, take it away. You can go to the next slide if you want to.
Nice. And thank you so much. And before I start talking about Masters of Maternity, I also wanted to share just a little bit about some additional statistics that doulas help improve birth outcomes. First thing I wanted to mention is that studies suggest that increased access to doula care, especially in under-resourced communities, can improve a range of health outcomes for mothers and babies, lower healthcare costs, reduce C-sections, decrease maternal anxiety and depression, and help improve communication between low-income and racially, ethnically diverse pregnant women and their healthcare providers. As Anne mentioned, a lot of the families that I personally take care of and other doulas that are on our directory, they are able to connect and build that rapport. And so because the doulas understand childbirth education, they understand the process, they understand their options, educating educating the families empowers them, and it helps them feel empowered to speak up in those spaces. Researchers also found that overall, people who have continuous support of doula support, again, 25% decreases the risk of cesarean section. 8% increase in likelihood of spontaneous vaginal delivery. A lot of moms come to me and they ask, hey, I had a C-section before and I want a vaginal birth. How do I do that? Oftentimes they're having trouble finding a provider that will care for them, that will allow them to have a trial of labor to see if they can achieve a vaginal birth. Some people are robbed from that experience, especially when they don't have a doula. So a doula empowers and helps connect them to the right resources so that they can have the birth experience that they want. 10% decrease in the use of any medications for pain relief. Doula care is a form of pain relief. It's a comfort measure. And so a lot of moms are able to have limited amount of medications used in labor or just remain unmedicated in general, which is beautiful to see. And then also they help shorten labor by 41 minutes on average. And these statistics, I can keep going on, but a lot of these statistics have come from Evidence-Based Birth, which is an amazing resource that helps moms outside of just doula care, but help moms understand their options and it's evidence-based. But just a little bit about Masters of Maternity. So my partner, who's on the call as well, Alita and I, we saw a problem. And the problem was that moms were dying, ultimately. And we wanted to develop a solution. There's many, many problems I can go over, but that are connected to the maternal mortality. But one of the biggest ones is what Anne has mentioned, is racial inequities. And so we wanted to create a one-stop shop for moms. We saw that moms did not have equal access to doula care, especially in Pennsylvania. Oftentimes moms are going on Facebook or asking families or friends to get help on finding a doula. And they also didn't know about the other resources that were available to them. So we created Masters of Maternity, and we started out with the doula, creating equal access to doula care. And so there's a directory that any mom all over PA can go on to and find a doula that best fits their needs. And we have so far connected over 70 families. So that's that piece, and it's growing. We ultimately want to be a one-stop shop for moms. So anything motherhood related, we want housed in that Masters of Maternity. But for now, we just have the doula directory. In addition to the doula directory, we have birthed a program called the FAM program, also known as Fund a Mom. And that program came from seeing personally me and other doulas that I've talked to, where we sit down with clients and they love us. We've connected with them, and they end up not hiring us because of a financial barrier. And so we wanted to create a solution for that. We felt like it is so important for families to be able to have the autonomy to find a doula that they felt that they connected with, that they trust, that they want to serve them during their pregnancy, their birth, and their postpartum period, and finances not be the barrier that turns them away. And so that's what the Fund a Mom program is. And we have an ambitious goal to fund 24 families in 12 months so that the 24 families are not turned away from having access to the doula that they felt like that best fit their family's needs. And I'm going to put a link in the chat. So if anyone feels led, they can donate. We just launched this month, and so we are now taking donations so that come second quarter of this year, we're able to have moms register to the program and then be able to pay for their doula service. And
Thanks.
I just put the link, I'm sorry, I just put the link in the chat now. So if anyone has any more questions, I also provided the link with more information about the Fund a Mom program. And there's a direct link to donate as well, if anyone feels led to donate.
Thank you. And I will put the report if anybody wants to go look, because like I said, the report is all encompassing. It does not just focus on maternity care. And it's something that I think anyone who lives in Pittsburgh should be aware of. And so, yeah, we're open to questions now. Looks like you have one there.
Let's see here. That's a good question. So we are funding, so typically the cost of a doula ranges from about $800 to about $1,200. And that is encompassing the whole entire comprehensive care throughout the pregnancy. So, you know, women are pregnant for technically 10 months and then they're there for the postpartum period. So we decided to fund a mom $1,000 for their service. So, and then the doulas will be a part of the directory. So it's nice that we'll do the connecting part, and then we'll also pay for the associated fees as well. Good question.
So I have a question. How do you advertise yourselves? Who do you reach out to and tell them about your service?
And service or my service? I'm sorry.
Oh, I guess yours.
Oh, okay. So we are on social media. We market heavily on social media, but I think being a part of conversations like this is helpful too. You know, just having, just being a part of different forums and sharing our mission. We are a new startup, so we're evolving, but I think spaces like this are very helpful because then you can share with your network as well.
Mm-hmm. Right.
Pittsburgh's a small town too, so word of mouth travels fast, and we've had a lot of interest in what Winter and Alita do. And really, there's been a lot of support for doulas in Pittsburgh and across the country in terms of funding as well, because the research is so heavily in support of the fact that they're changing outcomes. That's a really good question about doulas being covered by insurance and Medicare. It's slowly happening. For the first time, a UPMC has started to cover doula care. It's not general. There's no federal mandate for paying for doulas, but it would really make a lot of sense because they, as Winter said, if a doula is there, they use much less resources in the hospital. They have lower C-section rates. They use lower amounts of pain relief measures. They have more full-term babies, so they don't use the NICUs as much. It's just really hard to get them to get the insurance companies, especially Medicaid, to cover it. Do you want to answer that too, though, Winter?
I think I'm trying to see if Alita is still on, because she's actually a part of the Pennsylvania Doula Commission. And I feel like she could thoroughly answer that question. I'll see if she.
I'm here.
Oh, okay, perfect.
Hey, yes. So the Pennsylvania Doula Commission is taking strides to ensure that as a state, we are becoming more birth friendly, especially from a doula perspective. So we have actually just recently, most recently within the last month, released a Pennsylvania State Perinatal Doula Certification where doulas can actually submit for reimbursement if they're going through a family who's using Medicaid, as well as working with hospitals and MCOs to ensure that we're working towards getting all doulas covered under different insurances and employers. Those are strides that we are going to continue to take. Also, there are different ways that doulas can actually get reimbursed. Some, like TRICARE, military insurance, they offer reimbursement. So some private insurances do cover doulas. If you're, I mean, as you can imagine, if you have private insurance, you typically tend to be within a more privileged population. But I'll say all of that to say that the Pennsylvania Doula Commission has made history already in just making sure that there is a route for doulas to get reimbursed through the state, and we're continuously evolving what that route looks like. So to answer that question, yes, and Winter, if you have the link for that, we can share that information as well.
Awesome. I see Connie has a question as well.
Connie, you're muted.
You're on mute, Connie. I'm sorry.
Yeah, so I think you threw out some shocking statistics to me, and I'm having trouble sort of placing them where they would go. I was shocked to see how poorly every woman in Pennsylvania, those were Pennsylvania statistics, or Pittsburgh?
Pittsburgh. Yep, that's
Pittsburgh. How far we are below a median city, and then African American are even further below, twice as far below as the white women in the city. And is there any insight into why, with all of the healthcare that we have, because you also said things like, it is not level of education, it is not income. So I'm assuming that if that's not the natural thing you think of is that people that are poor don't have health insurance, so they don't go to the doctor. But you said that's not the problem. So I'm just trying to get an understanding of what you really think the problem is. And even if you say racism, what about race? Like if this rich person goes to the doctor every time they're supposed to, does the doctor just not give them the health care they're due? Or
yeah, that's a really good question, Connie. So there's been studies done actually on medical students and implicit bias, and the fact that medical students overwhelmingly still, the last study I saw was from, I think, 2019, still think that Black populations have higher pain tolerance than white populations. So they're given pain medicine at much lower rates. So it really is a system of racism. So there's racism in our medical education. There's not a lot of implicit bias training. Excuse me one second. Sorry. I don't know if you heard, but my husband's away tonight working, so I've got 3 kids in the background. So those problems directly translate. This isn't, malintention. Sometimes it is malintention, but it absolutely points back to racism. And for Black people in Pittsburgh, it's a very racist city. It really is. And that is clearly translated into our healthcare. And I just drive this point home. We should be ashamed that a Black woman can go to 97% of other same size cities in the United States and have better outcomes than in Pittsburgh with all the healthcare we have here.
so here's a question I have just to follow up. Today, probably 50% of my doctors are not white. So, I mean, are they being the discriminators?
Yeah, that's a really good question. I would probably argue that are they Black, or are they East Indian, or
one or more Indian, but one Black?
Yeah, so I'm really glad to hear that there's a Black provider, because there are some very good studies on Black providers, and the fact that people who receive care from Black providers who are Black themselves have much better outcomes. They, in fact, in obstetrics, they have lower C-section rates, they have lower complications. And, you know, Black providers do come in with less implicit bias when they're taking care of people. So I'm not calling out specific providers for their racism, which when I talk to healthcare providers, this is a really hard thing to hear, because we all get into healthcare because we care about taking care of people. You know, we want to take care of everyone the same way, but we are working in all kinds of systems of racism. And there has to be an intentional effort to break that down to actually improve outcomes. And you can see on that one slide that white women are also not faring as well as white women in other cities.
Yeah.
So if we take care, if we work on systems to improve care for the most vulnerable people, care will get better for everyone. So there's incentive for everyone to care about this. But, you know, Connie, I'm sure you're a very like educated person. You show up here, you care about learning, and you had no idea that Black women fare this poorly in Pittsburgh. And so
I had no idea that white people fared that poorly in Pittsburgh.
yeah. And so this is something
And
that
I mean, and there's a reason, but I don't know what it is, because we have a lot of healthcare and we have competition between UPMC and AHN.
well, more
I did
healthcare is not the answer. More healthcare is not the answer, because we're doing a lot of prenatal care. Different healthcare is the answer. And that's why I'm explaining that midwifery and doulas are an answer. It is different than what the majority of people will receive in the United States.
So
and in
one quick question. Is the midwifery and doulas in addition to seeing a regular doctor or
That's
in replace of?
No, in place of, for low risk pregnancies.
Mhm.
So we don't do twins. We don't do people with diabetes or high blood pressure, things like this. But 85% of the population, now doulas do. Doulas take care of everyone.
Yeah, doulas can be everywhere. They can be at home, the birth center, the hospital. It doesn't matter, which is, you know, unique. But midwives, as Anne said, they address the low risk pregnancies, and so those outcomes are better in opposed to obstetricians.
So if you do the hospital ones, so you're then working with a doctor in the hospital, is that correct?
Not necessarily. You could go to a hospital and have be cared for by a midwife group. It's a little bit different just from being a doula, just because of the setting. But clients do have the option of going to midwives within a hospital setting as well.
Well, it sounds like the expense, and it's not covered by insurance, I'm guessing, for a doula, but the expense is a whole lot less than it would take to be cared for by a doctor.
Absolutely.
With better results. You know,
Absolutely.
that's the big point.
That's the big point. They actually decrease the cost.
Yeah. I listened to an NPR talk about, you know, where they had midwives of color and doulas, and they have found that the outcomes were so much better and the attendance was so much better just because of the trust factor. And I think a lot of times we don't understand the impact, you know, of racism and what it does to women of color. You know, just not being listened to, being thought that they're not, you know, all the things that subconsciously we have been subjected to over the years that are in the back of our mind that we don't really know. You know, it doesn't come out in the front. It's all subconscious. And as a result, we do these microaggressions. And I think it has an effect on women of color.
Mm-hmm.
And that's why they have such poor outcomes.
Yeah, that's the key factor, the implicit bias. And we all have it, even me being a woman of color. I'm not exempt from having implicit biases. And that's why we all have to do the work. Because we're all taught, it's all passed down from generation to generation. That's what Anna was talking about, the epigenetics. So we have to do the work. And as being believers, you know, just asking God to see people the way that he sees them, you know, so.
And I do want to give credit. Someone asked in the chat, or what are we doing about physicians? Physicians are, you know, I'm supervising in my new role. I'm supervising some resident physicians at McGee, which is, you know, the biggest place that people have babies in. And there are some trainings on implicit bias, and, you know, there is an effort, but there needs to be this needs to be identified as a crisis and to be treated that way, rather than, you know, a PowerPoint presentation that you log into and have to pay attention to, you know. And so, and same thing for midwives too. Like, there just needs to be, you know, sweeping anti-racism work across the whole country, but I think especially in Pittsburgh. And we can't attract and retain providers of color in Pittsburgh, you know, if this is how people are treated. I could tell you, since I've had midwives of color on staff, I can tell you about the overt racism that they've experienced in Pittsburgh hospitals. You know, coming through we're midwives, we come through in the middle of the night all the time. In all the years I've been in Pittsburgh, I never once have been stopped coming into a hospital in the middle of the night. I have my badge on, you know, and our Black midwives were stopped multiple times, even after showing their badges, having their whole bags searched in Pittsburgh hospitals. You know, where I elevated that to the top of security. It's unacceptable if you show a badge. One midwife walked in the middle of the night after a white male physician. The white male physician went right through. She was stopped and had to go through a metal detector, had her whole bag gone through. You know, I was furious. So we have a real problem here in Pittsburgh, and I'm so grateful you're all here listening and trying to be a part of the solution.
Yeah, I agree. And there's a quick question. Are doulas welcomed by other doctors in general? Typically, yes. A lot of the Pittsburgh hospitals are doula friendly. With the pandemic, it was a little interesting. But since then, they have opened the doors back up for doula support. I don't know if anyone else has any more questions.
Well, I guess we have 1 minute to go, so we can take that time to thank you for bringing us this distressing information. And I can't say we're glad to hear it, but we need to hear it. I also want to tell everyone that the next forum will be April 7th at 7 p.m. The title is Gun Violence Prevention 101. The speaker is Josh Fleitman, who is the Western Pennsylvania manager of Ceasefire PA. So with that, we thank our speakers, Anne and Winter and Alita. Thank you very much.
Thanks, everybody.
For having us. Have a good night.
Yes, thank you so much.
Thank you. Good night.
Thank you. Great job. Thank you.
Great program. Thank you.
Yeah.